Hi guys, it's Dr. Ellen Marmur, hashtag Menopause Derm, and I'm sharing with you my menopause journey, partially to demystify all that happens in our menopause. And it's just another awesome phase of life. So today we're going to talk about cardiac stuff. And I had a little cardiac journey where I have a family history of coronary artery disease, got my lipoprotein little a checked and LDL checked, and with menopause, all those things were becoming abnormal. So we did a deep dive into what does it mean to have cardiac risk, wanting to be on HRT, what's the data, and what are some of our options. So I have Dr. Jonathan Marmur and Dr. Ching-Lynn Chen here today, and they're gonna demystify it for us, so that's next. Okay, so we have Dr. Jonathan Marmur, cardiologist, Dr. Ching-Lynn Chen, OBGYN, and we are chatting about HRT and menopause and cardiovascular disease. So Dr. JM, do you have any comments for us?
So hormone replacement therapy, this is as a man, I think it's a good thing for women to be on, right? Because it diminishes their symptoms. But one of the concerns is the implications of taking hormone replacement therapy and cardiovascular disease. My understanding is that one of the largest, most important trials that have been done in this topic of hormone replacement therapy was the Women's Health Initiative, which was a very large study that really had as a primary interest to focus on whether hormone replacement therapy could, which was associated with an increase in malignancy, I think breast cancer. There was a hope, if you like, that the benefits of hormone replacement therapy, theoretically prevention of cardiovascular disease, because women are protected relative to men premenopause. Your estrogen exerts protective effects against cardiovascular health. So there was a hope that women may have to pay the price of increased risk of malignancy, but that would be offset by a protective effect against cardiovascular disease. The other major endpoint that was looked at in that Women's Health Initiative was use of hormone replacement therapy to prevent fractures and osteoporosis. So let me just focus on the cardiovascular component. It turned out that there was no benefit. There was no cardiovascular benefit to women in that trial. In fact, there was a signal of potential harm. That perception came under a lot of scrutiny because the trial randomized patients who were in the later postmenopausal, like the average age was above 60, and it turns out most women who are interested in hormone replacement therapy are earlier, like the mean age is in early 50s. So it didn't appear to deal with that question very well. But my understanding and the overall consensus in the literature is that while the Women's Health Initiative did not show any protective effect of hormone replacement therapy for heart disease, the understanding is that there's no harm. So you should not be denied hormone replacement therapy from a cardiovascular point of view. In other words, if you're a gynecologist, obstetrician thinks you're a good candidate for it, you have a lot of symptoms, there's a concern about osteoporosis, cardiovascular outcomes should not be the reason to take it, and it should not be the reason not to take it.
About that. So we know that estrogen increases your risk of blood clots. Does that fade into the cardiovascular risk at all?
Yes, there was a signal, I think, in that study actually of increased thrombotic risk, stroke, pulmonary embolism, for example. And my understanding is that, and this is something you could address, is one of the ways of avoiding that risk is to take it parenteral, right? Take transdermally, yeah. Avoid the first pass. Hepatic somehow reduces the risk of thrombosis, but that is a concern for sure. So if a patient has a prothrombotic disorder, is someone who would be at risk for thrombosis, for example, previous coronary stents, history of stroke, CVA, pulmonary embolism, that may be a reason to think twice about taking the hormone replacement therapy.
Anything else, Jonathan?
Another issue that did come up in conversations is the risk of coronary disease in patients who have early menopause, which my understanding is before the age of 40. There is a signal of elevated cardiovascular risk in those patients. And in particular, in those who've had a surgically induced menopause by, say, bilateral oophorectomy, that is a group that appears to be at elevated risk. So if I were in that risk category, I would do a full assessment, including some of the things you talked about earlier: LDL levels, lipoprotein a, maybe even coronary calcium score on a CAT scan. I would be very conscious of that as a risk factor. Yes.
What about echo?
I mean, an echocardiogram is almost like an extension of the physical exam for a cardiologist. It's a screening test to look for any problems at a valvular level. But the risk we're talking about is more at the coronary disease level, which, unless you had a heart attack, is not going to show up on a cardiac ultrasound. So it'd be more of a stress test would be the test for screening.
Dr. Chen, earlier today we were talking about sort of like being aware but not being like obsessed or neurotic with all of this information. And since I think May, when the New York Times article came out that said that so many women were being denied HRT, your office has had a lot of questions about it. So you had a great way of putting your philosophy. Do you mind sharing your philosophy in general, not data driven, but just sort of in general, about people in their 30s, 40s, and 50s and how to approach this concept of menopause?
Yeah, I mean, I think because everyone's menopause is so different, there's no way to really prepare. It's one of those things that there's no good predictive factors. Like, you don't know how old you're going to be when it happens. You don't know if you're going to get symptoms, which symptoms you're going to get. And I think that does, cause a certain amount of anxiety, not knowing what's going to happen. And I think all you can really do in your 40s, maybe when your mom reached menopause could be, a predictor, but it isn't always. So, again, we really don't have any predictors. And, your health in your 40s is really, requires different things than your health in your 30s. And I think that the more you can do to optimize your health in your 40s, and really, what I tell my patients, it's really back to the basics. I don't think there's any magic, supplements or whatever, but it's, your diet, your health, your weight, sleep, and your mental health. And, I think everything we can do to optimize those things will reduce your stress on the system, because when we hit menopause, those hormonal swings are just additional stress. So, and I think ultimately stress is just cumulative, right? So the bigger your cushion is to deal with all that stress, when those hormone changes come around, the more your support is, the better you can deal with them, ultimately.
So, and taking care of yourself in your 40s is different from taking care of yourself in your 30s.
The body is different, and I think that it is aging, and it's not like we're all so old or anything like that, but we are older, and the things that we require change. And so,
what about with respect to hormone replacement therapy? Are you kind of overall pro? Are you have a low threshold? Are you encouraging of your patients to get on it, like they shouldn't suffer, or are you more in the camp of you only should take it if you're really severely symptomatic?
I think I'm more towards the pro side, but I think we are beyond the days of there's no everybody should or everybody shouldn't, because I have plenty of patients who stop getting their period and they feel great, and if so they don't have the stress of the menopausal symptoms, say they're not getting hot flashes and they sleep well and all that stuff, then I don't. And I guess that's a question for you also, right? If you're not stressed by the symptoms of menopause, I guess that would be a good study, right? Is your cardiovascular risk still increased? Is it the stress of all the menopausal symptoms, or is it the actual presence or absence of estrogen?
No, I would think the loss of estrogen is significant. But it's interesting that the hormone replacement therapy doesn't seem to kind of reverse that risk. Also, you have the biggest risk factor for cardiovascular disease by far is age. So as you age, you're going to But it's interesting. Women go through this catch-up phenomenon where, I mean, the number one cause of death is still in women is still coronary disease or cardiovascular disease. So although they're protected, you look at the age, most clinical trials look at the age of onset for acute coronary syndromes, myocardial infarction. Women are delayed by about 10 years. And it's felt that's, because they're losing that protective effect of estrogens. Taking exogenous estrogen doesn't appear to prolong your protection, like you still are at risk. So,
Meaning taking HRT does not protect you?
no, it's not gonna. That's kind of one of the points that's made in the literature. Is that, I think there's some subgroups where there's a signal of benefit in certain dosing regimens and whatnot. But the big picture is, I think we mentioned that you should not take hormone replacement therapy to prevent heart disease, and you should not take it because you're worried about heart disease. Like it doesn't. It's a net neutral. But as you go into your menopause, you're aging, and so you're at risk for heart disease, because age is by far the most important risk factor for atherosclerosis. So I think I don't know. I'm kind of I kind of like the idea. I think the hormone replacement therapy, if it's not conferring cardiovascular risk and then it benefits you for osteoporosis and symptoms, strikes me as a positive thing overall. Like it's good news that you're protected. You're not getting, you're not paying too high a price from a cardiovascular perspective. But the malignancy risk, that would scare me a little bit. But I guess with surveillance and whatnot,
Okay, so can we just go back, because I thought HRT was a bit cardioprotective, because you said estrogen is protective for the heart, and so that's why women generally have heart attacks like 10 years later than men. But so if you have an early oophorectomy or early menopause, we talked about having a cardiac workup, and HRT itself is not going to help your cardiac outcomes.
But isn't the answer really that we just don't know? We just don't.
Yeah, I don't think the data is there.
Right.
Like I don't think the clinical trials are there.
Meaning it may or may not help.
Right.
Yes.
HRT may or may not help.
It's not that it does or it doesn't, but just the one study we have shows that it doesn't. But that's just one
Okay.
study. And
So
100%
therefore, you
agree.
have to go back to the regular cardiac workup and beyond. If you have high cholesterol, which happens for some reason, why does that happen? Like, why do your lipids change in menopause?
Well, part of it is your aging, right? So it's also, that's what I'm saying. Age goes with menopause. So all those things, all those factors worsen with age. So I don't know
maybe
that
it's indirect. Maybe
Yeah.
it's that because men experience aging on. I'm totally making this up, but maybe because men age gradually over time. It's different for women. I think the changes of menopause cause the aging process to happen at, I don't want to say like a cliff-like kind of thing, but it
more
is
like
much
an
more
accelerated.
drastic.
Right.
So it's more. It happens in a shorter period of time.
Right.
So the body compensates differently for men versus women, maybe.
Well, it just shows up more.
Yeah.
It's more a clear cut.
Okay.
Time, because it is clear cut. Like for men, that's not a clear cut time when they're reach a certain aging
I don't know.
point. I don't know even how you measure aging.
I think that
Good
it
point.
may have been. I don't remember, but I guess I could look at it. But there may be some signal of benefit and protection by taking hormone replacement for younger patients. But I don't think there's no definitive data. There's no definitive statement from any of the societies about that. But certainly if you're at risk from the surgical menopause or premature menopause, that would be a reason to consider, say, for a cardiologist perspective, be a reason to consider putting the patient on statin therapy earlier than you would otherwise have done. Right.
And for the patient to be their own advocate about that. Like I'm in my LDLs and it's like high 90s. I'm not at that cutoff of 100, but I have a family history. I think I should think about Crestor or some type of statin.
Right.
So
basically, from a cardiovascular point of view, the most powerful means we have in prevention, at least from drug therapy, is those agents that lower LDL, and the most commonly used is the statin group. So, there are risk calculators for who should get on a statin and at what age. And it may be that in women who have early menopause, those risk calculators don't take that into account, for example. And so I would consider a patient like that someone to look carefully at all the risk factors and consider early initiation of statin therapy.
Interesting. Well, okay. Thank you guys. Thank you for your information. There's a lot of kind of gray area when it comes to menopause at all ages, but this is really just us sharing information. We're all fascinated by it, destigmatizing it. Ask more questions. We are not telling you how to take care of your health, but we are just raising some information for you because I believe knowledge is power. Thank you both. Bye. That brings up a really good point. You brought up Ozempic and reducing obesity and that help for reducing heart disease. And we know that in menopause, our weight goes up. So Dr. Chen, so are a lot of your patients who are in menopause also talking about Ozempic, or what do you think about those types of medications for during menopause?
I mean, I'm definitely not an expert in Ozempic. I think I'm unclear on what the end point of Ozempic is. Like, can you take Ozempic the rest of your life? Or is Ozempic used to get you to a certain weight and then you are able to maintain your weight without it after you stop taking it? I'm totally all for, optimizing people's health. So I just don't know if Ozempic is, I don't know. I think everyone's looking for something that makes sense for everybody, or just something that exists. For some people, it's probably really great,
Yeah, no, I've noticed there's a very degree of variation in people's attitudes towards it. I think the data is you have to be on it lifelong, because the patients who stop it, they gain the weight pretty fast. So.
The new set point, right?
Yeah.
So specifically,
it's a long-term commitment, I think, and then that has potential health risks, that may take years to show out. Yeah.
Makes sense.
Can you talk a little bit more about the use of these medicines, Ozempic, Mounjaro, Wegovy, for cardiac risk? Specifically, we'll keep it within the menopause group of people who might be struggling with weight.
Oh, well, the most interesting thing from my point of view is that we, as in cardiology, never considered obesity, a traditional risk factor. Okay. The understanding was
very surprising, right?
Obesity was not seen as a risk factor. Obesity was seen as an associated feature, but not causal. The causal mechanisms were hypertension and diabetes, which tend to go with obesity. So people who are obese get type 2 diabetes, they become hypertensive. So the focus in cardiology has been treat hypertension, treat diabetes, right? And even there's data that people talk about an obesity paradox, which is that, for example, patients post-bypass who have obesity and you control for their levels of diabetes and hypertension, in other words, you eliminate that, those who are obese tend to have better outcomes. It's called an obesity paradox.
Oh, weird.
In the cardiovascular literature. So obesity, which never really been a focus for cardiologists, and I think these drugs, the incretins, I think they're called, the GLP-1, glucagon-like protein 1, glucagon, and then the GIP. I mean, I don't even know some of the acronyms. I'm not familiar with, but it's a whole new class. And the phenomenal thing about them is they are basically a medical form of bariatric surgery. In fact, the scariest thing right now is not to be an obese person, it's to be a bariatric surgeon. Because the bariatric, these drugs are doing to bariatric surgery what statins did to bypass surgery. Now, the interesting thing there is there's still a healthy number of surgeons doing bypass surgery, but there are a lot fewer of them. Right? Okay. And a lot fewer.
Wait, so go back to the new data showing that people have been...
it's fascinating to me that patients who are obese put on these drugs, as their weight comes down, you see that their MI, their cardiovascular endpoints also
their lipids come down, they get to
Yeah,
go down on their
all
statins.
this whole metabolic syndrome, you know, which includes glucose intolerance and inflammatory markers, and they all diminish. Also, tremendous impact on the fatty liver infiltration, which is becoming an important cause for cirrhosis. It's going to be wiped out by these drugs. They're the single most important development in medicine, in my opinion, in the last 10 years. They're going to revolutionize the whole way people think. They already have changed people's perception of weight. It's not your willpower and all this nonsense. It's basically a biochemistry.
Yeah, it's genetic,
It's
mainly.
biochemistry. And no, I'm very pro these drugs, but the biggest problem is, well, obviously, there's some frightening side effects, right? There's been an association in animals with thyroid malignancy, not in humans, but obviously there's concern about that. To my knowledge, I don't think there's a signal of that yet, and there's been thousands of patients followed for many years now with them. But it's obviously that's a concern. It's relatively new, these drugs. And then the other thing is pancreatitis is a bit of a scary complication. So, but most complications of it are the nausea, vomiting that people get.
And they're going to make it into a pill soon, apparently, right?
Yeah, no, there's oral agents already available, but the clinical data is the sub-Q injection. Biggest problem right now is a shortage of the drugs. Patients can't get them, diabetic patients can't get them, and insurance companies don't want to pay. So you have to kind of, you have to beg, borrow, and steal, so to speak, to try to get them.
Just a note to people, my office has been offered to sell like a formulated equivalent to Ozempic in my office, and there have been a lot of warnings that these pharmacies that do what's called compounding and sell it to doctors and to weight muscle building places and stuff like that. So if you see something that's not FDA cleared, do not buy it, because it has led to some very critical side effects. Okay, so
the only other thing I would say about perimenopausal weight gain is that there is also a theory that fat cells also make estrogen. So there's a theory that weight gain that happens is potentially to compensate for the decreased estrogen production from the ovaries. So I think it's, in a way, within reason, and we're talking about maybe under 5 to 10 pounds of weight gain would be reasonable, without hopefully increasing your cardiovascular risk. But maybe there is some benefit, and I think the expectation to really look exactly the same in your 50s as you do in your 40s is also not so realistic and not necessarily the right goal, although I don't think any of us would pretend to be happy about being 5 to 10 pounds heavier than we used to be, but there's that.
Interesting. That is true. So the fat has is it a paracrine? So like the fat cells themselves are trying to compensate for our loss of
theory,
estrogen.
yeah.
That's amazing. All right. Well, there we go. So much. Thank you both very much. Have a great week, everybody.